So targeted therapies, we believe it to be smarter therapy than chemotherapy. Chemotherapy kills rapidly dividing cells, so they're not often targeting something specific. So I tell patients a lot of times that chemotherapy is like a bomb. It's very effective, it goes off, it kills off kind of everything around it. Targeted therapy actually targets either specific mutations or specific proteins that are known to be secreted on the surface of the tumor. So we call it smarter therapy. So I'll talk a little bit about how some of the targeted therapies are personalizing the approach that we have for a lot of the patient care that we do now. And in a lot of other tumors, we're using targeted therapy a lot more, and we're extrapolating a lot of the data from other tumors to see how effective they are in bladder cancer. So I first wanted to give you a little bit of background in terms of the Cancer Genome Atlas, or the TCGA. You may have heard about the TCGA. It's a very important effort. It was initially started back in 2006, and it was so successful that it was expanded in 2009. It was led by the National Cancer Institute and the National Human Genome Research Institute with a plan to identify genomic changes in more than 20 different types of human cancers, including bladder cancer. It compares the DNA in normal tissue and cancer tissue from the same patient with the goal of creating a genomic atlas available to everybody. So the TCGA, it looks at the tumor and it looks at the histology, which means it looks at the cells, it looks at the DNA, it looks at the RNA, it looks at the protein, and really kind of comprehensively describes the tumors that we're seeing in bladder cancer, so we can understand a little bit more about what is driving these tumors to show up. You know, what are the mutations that we see that are present in these tumors? So you can go to the next slide, and this is, the next slide is actually a little bit busy, but I'll explain to you what they are. The first column are the genes that were identified. So the TCGA in bladder cancer, they looked at muscle invasive specimens, and they identified over 30 genes that seem to be very important in the development of bladder cancer. And the great thing about it is that there are a lot of targets for those genes. And there are a lot of therapies that are currently being developed to target those genes and those specific mutations. And the last column is the NCTN, or the clinicaltrials.gov number for a lot of these clinical trials, just to kind of highlight how many clinical trials are currently ongoing, looking at targeted therapy, targeting specific mutations that were described in the TCGA. And we're also moving to personalizing the treatment that we give patients specific to their tumor, because although patients may have bladder cancer, some patients respond and some patients don't respond to therapies that we use. So why do some tumors respond versus the other? For example, this is a schema of kind of the ideal clinical trial scenario for the personalized approach, where we are taking a biopsy from the patient, then profiling it similar to the way that it was profiled in the TCGA and looking at the mutations, and then selecting the therapy based on the mutations that the patients have. And this is a trial, this is one of the many examples of personalized therapies that are currently going right now, testing this approach in bladder cancer and other cancers. So I'm going to move off from targeted therapies to immunotherapies, because I think we have a lot to talk about. There's definitely been a lot of excitement on immunotherapy in bladder cancer. And immunotherapy is a completely different approach than the standard approach that we used to have, where we targeted the tumor. We tried to kill the tumor or use targeted therapies that specifically were aimed at the tumor. Immunotherapy is actually what it's doing. It's aimed at your own immune system to try to make it recognize the tumor as foreign and attack it. So it's definitely a very novel mechanism to approaching killing of the tumor using your own immune system. So we're not targeting the tumor, we're targeting the immune system. So this is a picture kind of explaining the immunity cycle as we see in cancer. So on the left side, it's a bladder. That's a schema of a bladder. And then if you look at that mass, that's a tumor. And that's been magnified right there, just to kind of highlight the immunity cycle that is supposed to go on. So you're supposed to, your immune system is supposed to recognize the tumor. The tumor secretes these proteins that are called antigens. And then the lymphocytes, which are your immune cells, that's the purple cell that you see there, kind of picks it up and says, hey, this is foreign, takes it back to the lymph node, where the lymph node creates all these other immune cells called T cells that are specific to that antigen to kind of go back to that tumor site and kill the tumor. But this perfect immunity cycle doesn't happen because the cancer can produce an immunosuppressive environment by a lot of different mechanisms, but one of the mechanisms that we're going to talk about is targeting PD-L1 or PD-1, which are proteins that are either on the cell, on the surface of the immune cells or on the surface of tumor cells, and they bind, and then the cancer says, oh, I'm not foreign, I'm actually part of your body, and your immune system doesn't attack it. So these new therapies, these new immunotherapies that are PD-1 and PD-L1 targets are actually inhibiting this natural T-cell immunity cycle that should go on in the body. So what the immunotherapies are doing are letting your own body just go back to the normal cycle so the tumor can be attacked. I wanted just to kind of talk about this year at our medical oncology meeting at ASCO, there were a lot of immunotherapies that were presented, a lot of immunotherapy trials that were presented and that have shown that they work in bladder cancer. The atezolizumab study was presented last year, actually, so we knew about that one. And that one had shown that it works in bladder cancer in terms of shrinking tumors in patients that have already received standard therapy and it didn't work. So other companies have also developed similar drugs, either targeting PDL or PD-1 to see if they can also have efficacy in specifically in bladder cancer. And these therapies seem to also work just across all cancers, or across many cancers, I should say, that have been tested. Initially, the studies were done in melanoma. They've been tested in kidney cancer, lung cancer, and have subsequently shown that it works and are FDA approved now for other cancer types. So we heard about 5 agents at ASCO that are checkpoint inhibitors that actually have shown to shrink tumor in bladder cancer patients, and that's atezolizumab, nivolumab, pembrolizumab, avelumab, and durvalumab. So that's, and of course they have very long and complicated names, but those are the 5 so far that have all shown activity and very similar. About 15 to 25% of the patients have tumor shrinkage. And what's really exciting about the shrinkage that we're seeing is that it seems to last a long time, or longer than we would see with chemotherapy. That was one of the disappointments in chemotherapy, is that we can kill the tumor, we can shrink it, but there's always a little bit left, and then it starts growing back again. And it seems that with these checkpoint inhibitors, the effect lasts longer than we see with chemotherapy. And we think it's because of the memory of the immune system. The immune system remembers that these proteins now, or these tumors, are foreign, and we should continue to attack them. So a lot of exciting research that was presented at ASCO, and we have a lot of exciting drugs that have shown activity in bladder cancer. And I think Betsy now will talk a little bit more about what direction we're heading in terms of immunotherapy.
Right. So thanks, Andrea. That's a great overview of immunotherapy. So just to echo Dr. Apolo's comments, this is particularly exciting in the world of bladder cancer, which has in patients with bladder cancer that has spread, or metastatic incurable bladder cancer, we've been relying on chemotherapy. Chemotherapy works very well for a small group of patients, but has limitations that I think you just heard about in terms of how well they work, how long they work, how specific they are. They're not very specific. And so when we first saw the immunotherapy agents working in our patients with bladder cancer, we got very excited that this is sort of a new approach or a new trajectory. So while Dr. Apolo mentioned the 5 agents currently being tested in bladder cancer, one thing that's important to note is they're really all in the same category. These are all inhibitors of the PD-1 pathway. And so again, I know that's a technical term, but they all inhibit the same T-cell tumor interaction, again, allowing the immune system to recognize and attack the cancer. So we're excited that so many companies are interested in testing these in bladder cancer. We're very excited that one of them was just FDA approved, that is atezolizumab, and that was approved based on a single arm study. So there wasn't a direct comparison to chemotherapy. And that means that that drug can now be used outside of a clinical trial for patients with bladder cancer that's metastatic or incurable and who have had prior chemotherapy. But of course, we're still trying to improve. We're not satisfied with just having one agent approved in one setting. We want to learn how well these work, and we want to figure out ways to make this group of agents better. And so the slide that you're looking at now shows really the trajectory across bladder cancer stages. So on the left, the orange box showing non-muscle invasive bladder cancer. Those are patients who do not necessarily have incurable disease, but in some cases, that disease can live, the cancer can live and crawl along the surface of the bladder, even though it doesn't invade. It requires cystoscopies, treatments instilled within the bladder, such as BCG, and sometimes those treatments don't work. And so there are clinical trials looking to see if giving, in this case, we're highlighting here the listed trials, pembrolizumab in this setting will help improve the response to BCG or on its own get rid of the bladder cancer. Moving down the trajectory, there's muscle invasive bladder cancer. That's cancer that's still, as far as we can tell, located in the bladder itself, but the cells have dug down into the muscle, showing that they're on the move and that they are prone to spreading. And so in that setting, we're still treating with the intent to cure the patient, but we're looking at incorporating immunotherapy along with chemotherapy, either prior to surgical removal of the bladder, prior to or concurrent with radiation, or for patients who've had their bladder removed because of muscle invasive disease, but are at high risk for a recurrence in that setting, which is called the adjuvant setting. So again, we're looking at pembrolizumab, nivolumab, and atezolizumab in muscle invasive bladder cancer in all these settings. And once again, this slide just lists the currently open clinical trials. There are many more that we're working on and that are in development. Moving on to metastatic urothelial cancer, this is the setting where atezolizumab is approved. In fact, it's approved in that bottom box down there on the right, platinum refractory disease. We're still looking to see if atezolizumab is better than chemotherapy. So that phase 3 trial is ongoing, mostly outside the United States, and it's almost complete. It may be complete as we're speaking today in terms of accrual. And that's to really test the hypothesis that test the findings that we saw in the single-arm phase 2 that led to its approval to show that it truly is better. Pembrolizumab, a similar drug, is also being investigated in a phase 3 trial in that setting. And in addition, we're looking sooner to see if giving these agents by themselves in the beginning, before chemotherapy, helps people live longer. And those are the 2 blue boxes at the top on the right. So there's a combination study of durvalumab plus tremelimumab. That's a phase 3 looking at cisplatin eligible patients who are healthy enough and whose kidneys work well enough to get strong chemotherapy. And then there is a trial of pembrolizumab in patients for whom cisplatin or strong chemotherapy is not appropriate. And we're looking there to see if those work. And the last trial that we'll mention, again, this is just focusing on the PD-1 inhibitors, is a set of trials which look at maintenance immunotherapy. So These are patients who've had a nice response to their chemotherapy, and then after they've received 4 or 6 cycles, chemotherapy is paused and immunotherapy is brought in. And the idea is that immunotherapy is gentler than chemotherapy. It can be given for longer, and it may help people, again, live longer by introducing it in this setting. So this is just an overview of what we're doing right now. An important thing to know about clinical trials is that they open and close for a number of reasons. One, once enough patients have enrolled to get an answer to the question being asked, the study will close. And then rarely, if there's any indication that the treatment isn't working or that safety is a concern, studies occasionally close for that reason too. They're very carefully monitored. So if there's any safety issue that's concerning, it's evaluated critically, and studies can close for that reason too. And so because of that, at any given time when you're discussing a clinical trial with your doctor, down the road, there may be a whole different set of treatments available. And as Dr. Apolo alluded to, while we're very excited about immunotherapy, we're always looking for other mechanisms as well. And so those may be offered down the road to patients as clinical trials. So the next slide shows where we are now in terms of open clinical trials. So for immunotherapy, if you're looking for an immunotherapy clinical trial, even though there's an approved agent, there's still many trials looking to improve upon what we've done so far. Many are looking at combinations. And among these trials, many do not allow prior immunotherapy. So if a patient receives one immunotherapy as part of a trial, another immunotherapy trial is likely to not allow that because they're testing a similar mechanism. So among the clinical trials that do allow prior immunotherapy, you'll see that circle on the right. A small piece of that pie is looking at alternative immunotherapeutic approaches, whereas most of the trials for patients who've already received immunotherapy are looking at other mechanisms, either targeted therapy, non-immunotherapy combinations, or different chemotherapy approaches.
So I'm going to talk a little bit about rare histology, just because we've been talking about bladder cancer, and when we talk about bladder cancer, we really mean urothelial carcinoma, or the cells that line all of the urinary tract. So starting from the renal pelvis down to the ureter and the bladder and the urethra. But not all bladder cancers are urothelial carcinomas. There are some rare histologies, and I wanted to mention such as small cell of the bladder, adenocarcinoma or urachal carcinoma of the bladder, squamous cell carcinoma of the bladder, just to mention a few. And there are efforts ongoing to try to incorporate patients with rare tumor histologies into clinical trials. And the issue is the numbers. So these are small numbers. Small cell is less than 1% of all bladder cancers. Adeno is about less than 2%. And urachals are about a third of the adenocarcinomas. Squamous cell carcinomas at about 5%. So they're just really small numbers in order to have these large trials and ask these questions. So what a lot of investigators are doing are looking as to adding them to ongoing trials in bladder cancer and just having them as a separate exploratory discovery arm, just to see is there something that's working in standard bladder cancer that may also have an effect in these rare tumor histologies. And a lot of the focus has been on targeted therapies, targeting specific mutations, because a lot of the rare tumors have specific mutations that may be associated with them. But they're also now being incorporated into some of the immunotherapy trials as exploratory arms. So that's very exciting, because if we do see efficacy in these rare tumors, then we can actually open up a trial that will really be a big effort nationally or internationally in order to have a good number of patients to say, yes, this works or this doesn't work. Because, you know, I can have a patient where I have a good effect from a therapy, but that's called anecdotal. You know, that's my experience. And we really would like to have numbers to see in, for example, 100 patients treated with this type of cell type, how many of them do we expect to have a response or tumor shrinkage? So there are a lot of efforts to try to incorporate rare histologies into bladder cancer trials, and these are not as available. Clinical trials are not as available in rare histologies, but I think more and more clinical trials are incorporating them to try to explore new treatment options, because the treatment options have been limited for patients with rare histologies.
So I just wanted to say a word about chemotherapy. I think Andrea described it well before, saying it's sort of a non-discriminatory approach to attacking the cancer. It kills rapidly dividing cells, and I like the analogy that it's like a bomb. It's very effective, but non-specific. I think that being said, we can still be smarter about how we use chemotherapy, and we've been looking for what we call biomarkers or clues in a patient's tumor DNA, patient's DNA, and patient's blood that may indicate to us that chemotherapy or other treatments may work very well for an individual patient. We do know that a subset of patients, maybe 10 or 15% of patients with incurable or metastatic disease, live for a very long time as the result of chemotherapy being effective at controlling their cancer. Some of those patients are on various chemotherapeutic agents for many years, but others are on for a period of time and then have chemo breaks or long holidays in between where they're still doing well after chemotherapy. So there's a lot of active research looking to figure out which cancers will be the ones that are exquisitely sensitive to chemotherapy, and we don't want to give up on this modality for those patients for whom we know it will benefit. And so on the next slide, we'll show you an example of a trial that we're looking at to, again, refine how we use chemotherapy. So chemotherapy given before surgery to remove the bladder, we know helps people live years longer and helps increase the chance of cure in any individual patient. We've been giving this to hopefully everybody who qualifies, or that's the recommendation in our guidelines. What we'd like to do is understand which patients will have their chance of cure increased by chemotherapy, identify them, and then be able to selectively offer them the right chemotherapy. So this is a clinical trial that's open around the country as part of the intergroup, looking at patients' tissue samples, which are collected. Patients then go and get standard chemotherapy. Either one regimen is GEM-CIS, the other is MVAC accelerated. We don't think one is better than the other. We're just looking at both. And then their outcomes are measured. And what this trial will do is we'll learn more, of course, about how well chemotherapy works in the modern day in this setting, but we're also going to learn from looking at the biology of each tumor, whether there's a signature or a sign in those tumors that tells us whether or not a patient will respond. And so this is a really important study that I think we'll learn a lot from and be able to be more specific and strategic in how we apply chemotherapy. So as much as we're always looking for the next new thing, we won't stop looking to develop new drugs. We don't want to give up on the old ones for the patients for whom they'll be helpful. And so chemotherapy falls into that category.
So combination therapies, Betsy just talked about chemotherapy. Chemotherapy works, and it remains the standard of care for patients. We have found through clinical trials that some targeted therapies also work, and we have found through clinical trials that also immunotherapy works. So how about combining these different treatment modalities to see if we can get more efficacy, to see if we can get more patients that are having tumor shrinkage? And there's a lot of ongoing trials now combining immunotherapy with chemotherapy, immunotherapy with targeted therapy with chemotherapy, or two different targeted therapies together, or two different types of immunotherapies together. So there are a lot of efforts right now to try to combine it with, of course, one of the most important things is safety, making sure that that the toxicities are not overlapping and that that it's safe to give. So that's why they have to be done in the context of a clinical